und Easy Health Icon.
Christian, God works in mysterious ways. I went all the way to Baragwanath Hospital only to find that I'll start a thing. When I now came back, and I was the head of neurosurgery at Medunction of the physiology, the one heart is pumping more than the other for two. The other one is pumping, but not strong enough. And then the one with a weak heart had kidneys that were cleaning the blood from both. And because when it went the other side, it was already cleaned, so those kidneys were not working. So when you separated them, it became immediately obvious. The one with a weak heart, the heart couldn't continue to pump. And you see, if we knew that, if there were tests that could be done, that there can be interdependence, it wasn't a thing that was written about then. If we knew that, you would have extended the operation, a 24-hour operation, by another 6 hours by saying, let's take the working kidneys to the other side.
Transplant to this side.
Remove one and take one to the other side. So that would have worked.
Yeah.
Yeah.
But the technologies those days were also not so great.
Yeah,
you know,
well,
I mean, to investigate and test the functionality to the extent that it can be done today.
Absolutely, yes.
Then there were the Banda twins.
Oh, then there were the Banda twins.
From Zambia.
Yeah, then there were the Banda twins from Zambia because everybody knew there was activity in this area. And then the Banda twins, when they came, I happened to have been in Zambia on a meeting of the doctors. You know, it wasn't a congress, but it was a meeting of a pseudo-political meeting of the doctors. And when I was there at intermission, as we were having tea, somebody approached me to say, we hear you are here. We want to tell you that there's a set of Siamese twins in our hospital. We would like you to come if you have a chance to have a look at them. And then, of course, I gladly went over and I found them. Not quite the same as the other two that we did, each one with its own intrigues. And so they look at me, I say, how far have you gone with these, investigation-wise? So they say, no, 2 weeks ago we had sent them to Cape Town so that they can do the investigations of the bloods and everything. And now they were back, and the vessels were showing clearly. So I said to them, what did the Cape Town people offer? They couldn't say in detail, but they were not happy. You know, they said, no, let's hear what you can do. So they said to me, what can you do? I said, look, all I can do is we can bring him to Garangua Hospital. I will get Ben Carson because we have a similar experience. We can combine our experience and operate. We've learned a lot from the ones we did. Or they were happy with that. So in no time, the patient, the twins were brought there. And of course, I flew to Johns Hopkins Hospital, show him the pictures and so on. So the plan was made. This time, in the investigation, I must say we have Professor Sateghi.
Yes.
Yeah, he's Professor Sateghi is the head of nuclear medicine. So those are the ones who do the testing. So I said with Sateghi, Sateghi, we don't want to make a mistake like we did before. We know everything looks normal on these kids. But you must test for us each organ in isolation. And of course, he devised a plan that would show how this heart is working, and you would actually get the actual function. It's got to do with when there's metabolism, there's an uptake of radioisotope metabolites, and you can see the uptake and the utility, and it gets bright. So he gave them a clean bill of health. He says, no, both hearts are fine, both kidneys are working. And so we went ahead and separated them. And incidentally, they're the best result up to that time that the world had. And I would say even now, because some 10 years when I was in Zambia, those boys were in a regular school in Zambia. It's a pity I then left Medunsa, came to University of Pretoria. I don't know what happened thereafter. But there were teenage boys. They were doing primary school in a regular, not a special school, in a regular school.
So you have left a mark then and have contributed in the area of separation of conjoined twins, even though obviously there's more to you than just the conjoined twins.
The big problem with us is that we are not in the highlight, and that's because of many things. But the biggest one being understaffed and overworked, over-resourced, because the publicity that this should have had in the medical journals should have been a lot more. You do know that in England they did things later, highly publicized. So, and also in America, much later, highly publicized. So these are some of the things about our working conditions. If you work in a place which is not properly resourced, people don't know about you. But I'm happy that people like you know about us.
Well, maybe it's because I'm a colleague, the one who left school early. Right. So, looking at your time now at Medunsa and also at University of Pretoria, producing other neurosurgeons, any areas of highlights or, pride, some of the students that you would say, when I meet this young man or young woman, I just get full of pride because they went through my hands, they passed through my hands, and I'm so proud of what they're doing.
I'm actually proud of all of the students that I trained. They did not disappoint me. They did well. All of them finished. I think one or two towards the end had problems, but later finished. And it's not unexpected. It's not unexpected because remember what the old man said when I said I want to be a scientist and an engineer. And he said, the future is not there for you. So all blacks who were bright ended up in medicine. There was no alternative for them. So it's not surprising. And I knew you could train them to be anything. And I was never proved wrong. I'm proud of them.
In your training and also as you are now leading as an HOD of the neurosurgery, any challenges or difficulties that you encountered as a student or as a head of department who wanted to make things happen? You talked a little bit about resourcing.
Yeah, no, the resources, they are a far cry of what they should be. We are not properly resourced. I can't say we're not getting the budgets that we need to get. But what I can tell you is that those budgets are not ring-fenced and used for what they're supposed to.
In fact, in one of the interviews, you do talk about the issue of corruption.
Absolutely.
That corruption is robbing South Africans of access to quality, healthcare, because we're spending about 8.5% of our GDP in healthcare, similar to the amount spent in places like Germany and others. Right. So, as a country, the proportion of what we're spending in healthcare is actually okay.
Yes.
It's better than most countries. The only countries that are spending more than us as a proportion of GDP are the Nordic, countries, your Sweden and Norway's, those kind of countries. It's not Nordic, sorry, Scandinavian countries.
Scandinavians, yes.
Yes,
Yes.
but they spend 12, 13%, but then obviously it's a different way of doing things.
Yes.
But here we're spending a lot of money,
Absolutely.
but we are not optimally utilizing the money because...
So that begs the fact that it is not the budget. The budget, as you say, it's in that order.
Yeah.
Of 8.9% of the GDP, or 8.5%
Yes.
of the GDP. So it is not utilized for what it's intended to. When it comes down to provinces, it is not ring-fenced. And so you throw it in Gauteng, and maybe there's a clinic that needs this year, HIV program there. Now, when the whole budget shrinks, nobody has anything to spend, including us, who had a lot more that could have been spent. But we end up with zilch. That's why we always wanted to actually level the playing fields, because obviously it depends from province, it differs from province to province. Unashamedly, I can tell you the Western Cape is doing better than all the other provinces. Probably there's less.
Is it because it's led by a different political party? Maybe there's less corruption there? Or, I'm just talking.
I would say there's less corruption there. Whether it's because it's led by a different party, I wouldn't think so. I don't know whether it's because of the environment there. Most people, there are lots of Europeans who, when they come here, they want to go to the southernmost part of the country. Should anything happen, there's nowhere else, that type of thing. Even ex-Rhodesians would go there. But the truth of the matter is, they doing things better than other provinces. That I'm the first one to say.
Even in the education sector.
Yes.
If you look at the matric results that have just been published last week, they did much, much better than any other province overall.
So it's a shame.
In terms of the quality of the passes.
It's a shame that it's the only place you could say that's not run by blacks. But that doesn't represent you and me. I think other people are terribly misrepresenting us.
Looking, at if you were asked to be a minister of health to reorganize the healthcare system in South Africa, you were given carte blanche, no limitation of anything. What would you do differently?
Yeah, I would nationalize medical education. I would, and in fact, and I don't know that when I was president of the Health Professions Council of South Africa, I was working very closely with Dr. Motsoaledi, who was the National Minister of Health. We worked quite closely, as it should be. It doesn't make sense that there isn't synergy between the two. I don't know, he also tried hard to level the playing fields of medical education. Just like university education in other disciplines are in the national education of the country. The faculties and the teaching hospitals are in provinces.
So the competency of medical education is residing at provincial level currently.
The important resources are controlled at that level, and so the playing field is not level. It depends where you are and so on. Like, our colleagues of Western Cape, they're doing better than us, they're better resourced. That's not because we're fools. We're simply not as well resourced. Motsoaledi wanted to level that playing field, and we supported him. And I think they fought and fought. Funny, one of the quotas that refused that type of leveling is Western Cape itself. And we were angry with them. We were saying, the idea is not to bring you down to our level, but to lift us up to your level. That was the idea. You know, I mean, when you put a good athlete amongst the strugglers, you are not wanting him to run slower. You want the others to try, and this is what we planned. And so the politics messed it up because it hasn't happened the way Dr. Motsoaledi planned to, even up to today.
Since 1994, there hasn't been a new medical school in South Africa since 1994.
Since 1990.
The last medical school was actually UNITRA Medical School in 1985. All right, in a homeland government. Only this year, we are going to have a real new medical school at University of Nelson Mandela University in PE. I can't talk about Medunsa, Sefako Makhato. To me, that is still one thing.
Right.
So one can't exactly say there was a creation of something new.
Right.
It was a rebranding, in my view, of what was already there.
Right.
So yet the population has grown, doubled in about, since then, with about 60 million population, and the need for doctors and other healthcare professionals has also increased. So we haven't kept up in terms of production, of the medical skills. Nursing skills as well, a problem. Colleges were closed when ANC came in. So the issue of human resource planning, to meet the needs of the country, which includes medical education, I think it's an area that needs a lot of attention for sustainable healthcare. We've got an aged nurse population in the country now, over 50. And we are looking at a situation. So the point you're raising around medical education and the fact that maybe that competency and the leveling should happen at national level. When you look at the NHI, the policies, the bill that they are coming up with, which is before Parliament, is actually talking about academic hospitals, and them are now going to be part of national competency. In each of the provinces, but run from the center, not under the power of the provinces, as So, which is in a way what you are saying, that there needs to be some control from the center that oversees what's happening across the provinces, with the hope then that there will be, equitable, resourcing and clear outcomes, for the healthcare system.
Yeah, look, there are a few points I can say in response to what we've just said. But let me start with the one that will correct the initial statement. As of now, which is end of February 2021, the medical faculty of the University of Limpopo is working, and in fact, their first products, their first graduates are going to be this year, which is in fact where I'm going to assist with the build-up of that university.
I'm happy to hear that.
That's right.
I'm happy to hear, because I thought it was just a rebranding of Medunsa.
No.
And then there was a time where there was a merger with University of Limpopo, and then there was a re-thing of SMU.
You were right.
De-linking. So I thought then it stopped there.
No, you were right. You were right that, by the way, the initiative was started by us at Medunsa when I was the executive dean there, and that we must have a satellite faculty there. But because the measure was fraught with problems, it had to be
demerged.
But then they picked it up to say, we will build our faculty. And in NST, they've been building it towards completion. So that's the one point.
Okay, there I'm glad you've corrected me there, and I'm very glad about that.
That's the one point. The other point is, the universities that we have are not 100% utilized for us. If we can take even 7 or 8 and utilize them properly for our needs, we would have done a lot better. Why do I say so? You'll have a lot of foreigners in these universities taking places of the people of this. I'm not saying we shouldn't allow foreigners.
Mustn't be xenophobic.
Yeah, I'm not saying we should be xenophobic, but truth be told, if you talk of universities, we have enough to build our own here. And of course, this program that takes people to Cuba, when at the same time VETS has so many foreigners in, doesn't make sense to me. You understand? So as I say, get me properly, I'm not saying we shouldn't have them, but the extent that things are happening, we could do a lot better. So that I accept that we are not doing well with the resources that we have. Coming to the one of National Health Services, the NHI is one of the best things that happened in England.
The NHS?
The NHS, yes. We call it NHI here. They call it NHS. And in fact...
it was after the war?
Yes, after
First World War?
No, the Second World War. Winston Churchill, that era. And of course it was the Labour Party that they decided we must go the NHS way, where everybody must have the health that the country can provide. And it's been refined over and over again. Today, the World Health Organization says this is the way we should go.
Universal
health care. President Obama, during his time, went all the way to do that. They scornfully call it the Obamacare, but that's the universal health care. Yes, indeed. I was in agreement with Dr. Motsoaledi when he moved us towards that, and I supported him from the position of President of the Health Professions Council. And I'm happy that it's continuing. People used to miss leaders and say, NHS is not getting well. We used to get this in serious debates, and I would shake my head and say, they think we're fools. COVID has shown the whole world how proud the British are with their NHS.
Yes, I mean, the countries that have dealt better with COVID are those with a universal healthcare coverage.
Absolutely.
And I interviewed the National Minister of Health last week on my channel.
Right.
And he actually acknowledged that and said, the more organized the healthcare system,
yes,
the better the chances of dealing with pandemics. And
Absolutely.
the UK has been one example of that.
Right.
In spite of the fact that the highest number of deaths in the Western world, let me say in Europe, let me say the Western world, because Western world will talk now the US with the highest numbers, but in Europe, Britain has not done very well in terms of the deaths, but in general, they've managed the pandemic much, much better than others.
In fact, as soon as they handed it over to the NHS, they are singing praises every time of the NHS, what they did to them. So they may have started a little later, but also the environment, the circumstances, the population densities have to be considered, in order to compare. You can't compare apples with bananas.
Yes.
So in fairness, I would say the UK has done well, despite... You see, one thing about the UK, why they always do better, is that they have a vocal society. They shout, the society shout. Like when people started saying the NHS is not working, it's because the British people were complaining, meaning go better. Not that you are bad, but go better. So that's what helped. We don't have a similar situation.
We suffer in silence.
I remember when Pravin Gordhan, I think he was a minister of finance, when he criticized the provincial system And he was saying the provinces look at education and health as their cash. Was the expression.
Yes, I mean, where they will loot,
Yeah.
yes. Because they've got the biggest budgets in any province.
Now, if you say a statement like that in a place like UK, they would not have survived a month after that. We laughed it off.
So you're saying the South African population is actually quite passive when it comes to...
We see a lion coming, we laugh it off until it bites us and we are no more.
Yeah.
That's what I criticize our community, that we're not on our toes with demanding
the
accountability from the government. Yes.
If anything,
cash cows is the expression.
Cash cows, yeah.
Yes.
Now, Prof, because we're working towards the end now, you know, you are in retirement, but you're not really in retirement. I mean, you are due to join the University of Limpopo, and you're going to be working Polokwane Hospital and what do you call the other hospital now? Is it Mangweng?
Yes, it's Polokwane Mangweng, one complex of hospitals.
Yes. So you're going in there to continue your journey to teach and to also provide the much needed specialist, you know, super specialist care that you have. So you are not really in retirement, you know?
Yeah, no, look, once a teacher, always a teacher, and no doctor can retire unless you are disabled.
Yeah.
So if God gives you health, He means you should help the needy, the people who need your health, for instance.
So at age 68, you still fit enough to stand and do those 14-hour ops?
Well, not quite. I mean, that would be insincere. Yeah. But I'm fit enough to train the people who are fit enough to do those ops, to train them the right way, production of medical students, production of specialists. Yes, I mean, I've been at Tembisa Hospital.
Yes.
It's a good thing, I must say, for somebody who's retired, for people to say, please come, we need A, B, C. Because that's what we love.
Yes, I mean, that's one of the things you did when you were at Steve Biko Academic Hospital in Pretoria.
Yes.
You decentralized neurosurgery, you know, capacity from where things used to be done in that center.
Yes.
Tertiary center. You actually took and built capacity Tembisa Hospital and also at Kalafong. Little bit about that.
Absolutely. Yeah, look, when I was head of neurosurgery at Steve Biko Academic Hospital, I was told of the satellite hospitals that feed into us, meaning that we should do the tertiary level work from those people. So I was sitting, working on complex operations from those feeding hospitals. Not just, in fact, not even just complex operations, even simple life-saving ones. They would all have to come there. So I realized this is a constriction. I tried to increase the capacity. Of course, the CEO was very helpful. Whenever I wanted more staff, he would give me, he never refused me. The issue was when it came to facilities.
The beds.
When it came to the beds of the hospital. When it came to the theater time. When it came to the beds of the ICU. Now, I would sit there with people wanting to come in, but they can't come in. And they die there. And when they die there, they die in my name.